Now, is this comfortable and everyone can hear me? Okay, not too loud? All right, good, because I don't think we can adjust it. So we'll just have to roll with what we've got. All right, thank you all for coming out tonight. It's lovely to see all of you here in person, and thank you to, I believe we have a few people joining us online. Hopefully they'll be back on or off, depending on when they've come. I'd also like to welcome all of our fabulous speakers for tonight, Rachel Sanford, Nusrat Jahan, and Telma Costa. I will give them a full introduction shortly and let you know what kind of fabulous background they've brought tonight. However, I would like to begin by acknowledging the traditional custodians of the land on which we gather, the Gadigal people of the Eora Nation, who have lived, loved, and raised their children on these lands for thousands of years. Throughout modern history, a particularly horrible method of colonialism has been restricting the reproductive choice and family planning of Indigenous people, whether that be through sterilisation, the introduction of new STIs, or notably in Australia, through the removal of children from families and the land they are so connected to. So I think it's important as we prepare to discuss these topics tonight to also think about them in a domestic context and consider how these issues have impacted Indigenous Australians and pay particular attention to the ongoing health impacts in these communities and what we can take away tonight and put them into our programs. So in saying that, I would like to pay my respect to all elders past, present and emerging of the Gadigal people and extend that respect to any Aboriginal and Torres Strait Islander people joining us today. And I would like to acknowledge that sovereignty of these lands was never ceded. So on to some general information about us. Women in Aid and Development is a membership organisation for all women who work in or aspire to work in the international development and humanitarian aid sectors, inclusive of trans women and non-binary people. We're part of a global community of professionals, and we'd love for you to join us in celebrating women across the sector, sharing our experiences and supporting and inspiring each other to pursue and succeed in leadership roles. You can connect with us and other fantastic women in the sector by engaging with our Facebook and LinkedIn pages. If you're particularly inspired by anything you hear tonight, we would love to hear what you've said, what you've thought, my brain tonight. And you're welcome to tag us in any posts that you make on Facebook or LinkedIn. And we also have some sheets of paper over near the food tables where you're welcome to write some comments or give us suggestions for future topics. Now, plan this and I need to shuffle my notes. So, finally getting to the point. My name's Jamie Lee McLaughlin, my pronouns are she, her, and I'll be facilitating this evening's session. I'm currently working with the Australian Red Cross in community mobilisation, and I have a background of experience in higher education and government. I'm also a member of the Women in Aid and Development Events Committee, which meets regularly to discuss ideas for these events, organise them and find our lovely speakers. I'd like to acknowledge my fellow Women in Aid and Development people here tonight, including our fabulous volunteers, our board members and our wonderful chair, Chris Franks, who unfortunately couldn't join us this evening. So just some quick housekeeping before we get into the good stuff. The bathrooms are just behind me over here to the right. Our emergency exit is the door that we came through. Please help yourself to food and drink throughout the night. And, oh, hi, Chris. And if there are any leftovers, please feel free to take some home with you. We don't want to waste anything. We will have plenty of time for chatting and networking after we've finished hearing from our speakers. So please feel free to hang around and get people's LinkedIn and further chatting because we love to see the networks that build from these kind of events. And finally, our session tonight is being recorded and you'll be able to find that on our YouTube channel in a few weeks once we get it all processed and uploaded. So, on to our topic for this evening, delivering sexual health and reproductive choice programs. Access to equitable sexual and reproductive health and education services is a crucial aspect of the international development agenda, impacting gender equality, health, and overall well-being, particularly of women and girls. Tonight, we will hear from our speakers who are delivering sexual and reproductive health services in the Asia Pacific and find out more about how their work underpins women's choices and gender equality, supports the Sustainable Development Goals and breaks cycles of poverty. We'll then have time for questions at the end. So I'll be guiding our discussion and can ask some questions of my own, but most of them are going to be coming from you if you're not being shy. So while you're listening, please make a mental note of anything that interests you and you'd like to discuss further because other people probably have the same question. So I'd now like to introduce our speakers for this evening. Our first speaker down the end here is Rachel Sanford. Rachel is a program manager on the international team at Family Planning Australia, where she leads projects across 5 countries focused on cervical cancer prevention, contraception access, and comprehensive sexuality education. These initiatives are delivered through DFAT's Australian NGO Cooperation Program and currently span 8 active projects. Notes again. Rachel also worked in Southeast Asia on HIV and maternal health programs. She serves as the international team's child safeguarding focal point, ensuring child protection standards are embedded across all programs and partnerships. She holds qualifications in communication, public health, and social work, combining interdisciplinary experience with a deep commitment to equitable, rights-based approaches to sexual and reproductive health. Our second speaker for the night is Nusrat Jahan. Goodness me. We're going well, aren't we? So Nusrat is a passionate global health and international development professional. A doctor by training, she chose to pursue a career doing the work that matters to her the most, public health and social justice. Having experienced firsthand how a lack of timely and accurate information can impact one's ability to realise their sexual and reproductive health and rights, she has spent over a decade advocating for health equity across Southeast Asia and the Pacific. A proud feminist and a strong advocate for gender equality, Nusrat's work centres on inclusion, local ownership, and breaking down barriers to access. She believes health information should be easily accessible, empowering, and culturally relevant. Her experience ranges from developing puberty booklets and consent education videos for Indigenous and culturally and linguistically diverse youth in Australia, to supporting comprehensive sexuality education and designing holistic health interventions with a life course approach that upholds the right to health in the Pacific. And finally, our lovely third speaker, we're very lucky to have 3 tonight, so please be very grateful to these ladies for all of their experience, is Dr. Telma Costa. Telma is a Portuguese medical oncologist currently working as a research fellow at the School of Public Health at the University of Sydney. She's been deeply involved in the Elimination Partnership in the Indo-Pacific for Cervical Cancer program, where she leads activities in the treatment space and supports the program's implementation in Timor-Leste. Additionally, Telma heads the technical team responsible for developing the clinical practice guidelines for the management of cervical cancer in Australia. Lots of very impressive names in your bio. With over 10 years of experience in oncology, Telma is a clinician by background who has previously spent time in Angola and Cape Verde in sub-Saharan Africa, where she supported the development of decentralized oncology units, further deepening her commitment to global cancer care. Telma is also a passionate advocate for patient-centered healthcare, strongly supporting the active involvement of patients throughout the cancer care pathway. Okay, so I'm very excited to hear from you ladies because that sounds like a fabulous wealth of experience that I think we could all learn from. So to start us off, I'll sort of ask each of you to give us a brief overview of what your career journey has been so far and how you came to focus on sexual and reproductive health. So Telma, I've given you the first mic. Would you like to kick us off?
Much. I'll open my notes as well. Good night, good evening, everyone. It's truly a pleasure to be here. Thank you for the invitation. It's wonderful to share this night with these 2 amazing speakers, Nusrat and Rachel. So as I said, in my bio, I'm a medical oncologist by background, originally from Portugal. And before I moved to Sydney, my professional life was almost entirely dedicated to clinical practice. I also had a long-standing, and that led me to the work in sub-Saharan Africa with global health, global oncology, and trying to adapt our knowledge to the reality of other countries that in terms of resources are more limited. So doing this adaptation to actually try to move towards better care in terms of oncology. So during my training, I took part on multiple medical volunteer missions, particularly in Africa. And initially, the focus was actually delivery of clinical services. But over time, I start to understand that probably in terms of sustainability, it would be much more interesting to actually try to work towards health system strengthening, building capacity, developing local protocols, and working with the teams that are actually there on the ground during the entire year and not just going back and forward and doing these vertical approaches that might be very useful in the right point in time, but they are not very long-standing. So having this in mind, that although coming back to Portugal, I had this passion growing, and that was always my idea to at some point shift or at least build this public health and global health skills. Also to share with you, and as a woman, that back in 2020, so 2020, I was also diagnosed with a breast cancer. So that led me to actually take a break, pause my life, and think more deeply about these career shifts, personal shifts. And that led me to moving to Australia with my partner and pursuing a totally different career. And that's what led me to work at the University of Sydney, where I am now. It's been almost 2 years and a half, more or less, working with this amazing team. Probably in one of the most impactful programs that I think are happening in the oncology, cervical cancer, particularly space in the region. So I'm really proud to be part of this amazing investment. And when I say investment, it's not just financial, it's also commitment from the funders, but also from the countries that are actually actively working with us. And I'll take the lead to, and if I'm extending too much, just cut me off. I'll probably stop here because the focus of the question was on the career and not so much on the program and on the work that I'm delivering, but what do you think?
You're very welcome to do a couple minutes talking about what you're doing now. I think that would give some really good context that people know what kind of questions they can direct towards you. So maybe
Perfect.
sort of what you're focusing on.
So this program called EPIC, and it stands for Elimination Partnership in the Indo-Pacific for Cervical Cancer. It's a program that brings together multiple partners. One is the University of Sydney, which is the leading organization, but then we work with Family Planning Australia as well, as one of them, the consortium partners, the Kirby Institute, the Australian Centre for Prevention in Cervical Cancer, and I made this pause because we say ACPCC, and I was trying to think about what it stands for. It's always difficult acronyms. And with also some international partners as well. So the union, the International Union for Cancer Control, which is an important civil society strengthening organization, UNITAID, and other international partners. And the aim of this program is actually support countries in the region, and we are supporting directly 8 countries in the region to set the ground or progress if they are already doing some work in terms of cervical cancer elimination. And I'm not sure if you're familiar with what does this mean. It does not mean eradication of cervical cancer, but actually bringing the numbers and the cases of cervical cancer so low that they are not a public health problem anymore. Because at this moment, it's still one of the leading causes of cancer death worldwide. So in if we look at low middle income countries particularly, it's the second leading or the first leading cause of cancer death for women in those countries. So it's quite an impactful problem. And the curious thing is that we actually know how to prevent it and how to treat it if we can't prevent it. So we have the tools, we have the knowledge to actually do it. And WHO, the World Health Organization, working with a lot of partners as well and a lot of researchers, including some members of our team, developed this strategy to actually try to eliminate globally cervical cancer. And it lays on 3 foundational principles. The first one is around primary prevention. So we know that more than 90% of the cases are related to HPV infection. So we have HPV vaccines, so we can actually act on primary prevention to prevent these cases to develop. So pillar number 1, HPV vaccination. Pillar number 2, screening. Because although when we start vaccinating, we'll be protecting our girls and adolescents from getting the disease later, because that takes long time, 10, 20, sometimes longer to develop cancer since the infection occurs. So we have a lot of women who didn't have access to the vaccine or were exposed to the virus anyway. So we have to do the secondary prevention, and that way relies on cervical screening. And we've been doing cervical screening back in the years, and probably, Rachel, you're going to talk about different methodologies. But that's been a learning curve on that space as well. And one of the most current, it actually changed the space of the screening, is HPV testing. So a simple test that actually detects the presence of high-risk papillomavirus, the ones that are actually very related to the development and to the lesions that can lead to cancer later if we don't act. So this is the second pillar, HPV screening. And then the third one is actually treating any precancer lesions or invasive cancer treatment. So if we act across these three pillars, we know that the countries will be well positioned to in the future, be able to eliminate cervical cancer. They are very specific targets. So what we want to achieve is 90% coverage in terms of vaccination, 70% coverage in terms of screening, and 90% coverage in terms of treatment. In Australia, which is a world-leading country in this space, it's actually expected that Australia will be able to be the first country in the world to eliminate cervical cancer, which is pretty amazing. And it's expected to occur on the next 5 years, potentially. So between 2030, 2035. So it will depend how we're going to behave from now on, actually. So using all this knowledge that we have, even from here, the experience in Australia, which is amazing, and again, leading this cervical cancer space worldwide, and transferring it to low middle income countries in the region that have a high burden of disease, I think it's quite remarkable, and we have the obligation to do that, actually. So EPIC is about that. It's about working and sharing the knowledge that we have, the experience that we have with the countries. So in practice, and as I mentioned, we'll be working with 8 countries in the region so far, open to more countries. It's been an amazing journey with additional funders coming to the table. So initially it was a DFAT-funded program. Currently, the Minderoo Foundation actually came to support and to expand the work, and potentially other funders as well. There's the Swire group, and I'm looking at Chloe because you've been working with them as well, that will help on this program. So as I mentioned, this comprehensive approach that we take with the countries doesn't focus only on the policy level. That's a big part of the work, working with the governments, discussing policies, providing that technical support, doing modeling to predict the needs. But actually it goes also to the other levels in terms of capacity building and actual implementation on the ground. So we have this multiplicity and multidimensional approach, not only in terms of the 3 pillars of cervical cancer elimination, but also in terms of the spectrum of where we act. And we go from grassroots on the ground and working with the teams that are actually delivering the services to the top tier high-level discussions with the governments to actually make these investments being able to be scaled up and being sustainable after the program finishes. So has one thing that as I said, the program has multiple things that excite me very much. But if I would have to select one to talk today, and it's going to be brief, it's about the introduction of a new methodology that's already here in Australia. So some of you might be familiar, which is self-collection of the vaginal sample to do the screening. And I brought one swab. So when we think about cervical screening, probably, and that happens to me, and what the model that we have in Portugal is still a clinician collected, speculating examination, all those barriers that actually came to my mind and that detract me to, or at least think, oh, due to screening, I have to go there. I don't want to go there, but there's a lot of barriers. And thinking about a method that actually will be self-collected with such a simple swab. Are you all familiar with these swabs? Yeah, sure.
Who is on old? Who's done the old speculum system?
Yeah, it's sealed, right? Yeah.
Oh, no, times have changed. It's not that. You remember
Pap
smears, that's what it was for.
Yes, so I'll hand the mic down to you if you'd like to mention it. Just for those of us online, we've just sort of done a little survey of the room of who's still used the old system in here, because yes, it's quite uncomfortable.
Yeah, sorry, I just shouted from the other end of the panel, who here's had a pap smear? So, but and we would promote pap smears, but we all hated them. Yeah, so no more pap smears. And that, I'll stop interrupting you, Telma.
But that was a great intervention. No more pap smears. So with this swab, and I'll pass it around if anyone has not seen it, it's actually empowered the women to take care of their own health, collect their own sample in a private space. And I think that was a game changer, not only here, but thinking about these settings where women are face so many other cultural barriers that we are not aware of, and thinking about societies that there's so much abuse, and thinking about the possibility of doing a simple test in their privacy by themselves, without feeling pain. It's pretty amazing. And the literature, and this is published, has shown that in terms of the screening rates has increased since the introduction of this new method, and the feedback that the clients, the women gave is really positive. And I think that's one of the big changers in terms of screening that we are using, and I'm very proud. And I'll stop here, just pass around the swab and open for discussion.
Yeah, no, thank you. That was very interesting. And honestly, I think we should encourage more of our speakers to bring a show and tell prop where appropriate, because it is, it's fascinating to hear about the work you're doing, but also to tangibly see, and it was something we can all, relate to as women as well, of, oh, this is an uncomfortable process. Obviously, the take up will be higher if you make it more comfortable. So thank you for bringing that. All right. And now we might move on to you, Nusrat, if you'd like to give sort of your history and your career journey and what you're doing in the sexual and reproductive health space.
And so nice to hear like how passionately you talk about cervical cancer and yeah. Sorry.
I just need the Zoom people to be able to hear you.
Okay, yeah, so very nice. So thank you for sharing, Telma. I think for me, I was thinking what to talk about today. Little higher. Okay, I'm not used to holding my. Okay, so I was just thinking what to talk about. So I just thought maybe start sharing some of my personal stories. It was way back before my career or even high school. So it was my first day in grade 6 in the school. And I remember it was first day. So, and then I was like, oh, and I think it was after my tiffin break. And then, and I went to toilet and I saw some stain on my pants. I was like, oh, what is happening? Did I hurt myself? Or like, how come there is some color? Like, it doesn't look like blood, but it's something. I was just like, and I didn't even know that I can ask someone about it. So I was like, I finished my school. I think my mom picked me up. And then we went home and then I said, oh, mom, this happened. And I said, oh, this is normal. Like, when you're at this stage, I have it. Every girl, when they're hit a certain age, they will have it. So you'll have it every month. I said, okay. So that was my introduction to reproductive health. So I think, so I am from Bangladesh, and if some of you maybe know of the country, so it's 99% of the populations are Muslim there. Just giving these facts if you're not aware of my country. So I think growing up, since I had my first period, I think it was always, I have a brother and I have a father, so two male figure in the house. So it's more like me and mom, we were always we had to be secretive about it. Like, you know, if we're buying period product, oh, you need to buy it, put it in a cover and put it in your bag and then store it somewhere where your dad and brother cannot see it. So I think this was my adolescence. And then we didn't have any education in school about your reproductive health, reproductive system, your body parts. So the first time I got to know about my body was my first year of my medical school when I learned anatomy. So that was when I was 18 years old. So I think that was kind of when I started to learn about, okay, this is how my body works. And okay, this is this. So fast forwarding. So I think, you know, coming from background and culture where, you know, I was experiencing those, and without knowing so many terms like contraception, like I would only know, oh, mom takes something every day, but I don't know, okay, I don't know what other contraceptions were. Like, these are all questions I didn't have a phone until I was, I think, year one of my high school. There were 2 years, and that phone only could call out and in, so no internet. So it's like, where do you get this information? And our like a national television would not have anything like that. So it's like very much hidden, secretive. Anyway, again, not too much detail. So yeah, I finished my medicine. Then after that, I practiced as a clinician for about a couple of years. And during that time, I made a decision, okay, I will do my postgraduate in public health, not in clinical medicine. And that was not a very welcoming decision. Like, my parents would not take it lightly, like they did not. So it was like they had high expectation, high hope that, okay, no, you have to be a doctor. Like, why would you do this? Like, they couldn't comprehend. And I think that was a battle I had to have with my parents. But anyway, I never regretted that decision. So very, very happy about what I chose to do. And then so I did my master's in public health back in Bangladesh, and then also worked, still working kind of a semi-clinical with drug safety and adverse drug reactions in pharmacovigilance. Sorry, am I too low?
No, I think you're fine. I think, Chris, if you're able to mute, thank you very much. We've just got more people joining online. It's all good. Please continue.
All right. So yeah, so I worked in around that space quite a bit, and finished my master's, then made a life decision to move to Australia. And I love study, but also I think coming to Australia, I think you need a visa. So, so it's like, okay, because I love to study, so maybe let's study a bit more. So why not? So then I did a master's in health service management here in Australia with Western Sydney University. And that is very similar to the study I did in public health, but well, there's another degree. And then I think after that, just was engaged with quite a few of the INGOs, then in a volunteer capacity and some small bits and pieces of work. But my first in Australian workforce, my first experience was with an organization called WiAD Foundations. If any of you know, so they are the peak body, New South Wales peak body for youth homelessness. And they were doing like a sexual health training for youth workers called Sticky Stuff. The name says it all, the Sticky Stuff. So when I was engaged with them, I was working on creating that face-to-face training into an online training, which was really, really fun exercise to do. I think I was like, yeah, my first formal job in Australia, working on Sticky Stuff. And working for these young people, but the training was, so it was quite interesting. So the training was for the youth workers, so not directly for the young people, but youth workers who deal with or work with young people very closely, and also for young people who are out of home care settings, so for the out of home care workers. So it's kind of, like when working on that training package, it made me realize my childhood and, I kind of felt very grateful to be in a position where I am contributing to something which will help young people like who I was some years ago. So I think which was nice. So that was the work I did with Y Foundations mainly, with, in addition to some other things. Then family planning. So I joined Family Planning Australia. So, there I first worked in the domestic team. I think we have two colleagues here, two friends here from family planning now. So in family planning, there are some work they do in Australia, and also there's an international team. So I think the first bit of my family planning journey was I was fortunate enough to work across two different teams, which was of the culturally and linguistically diverse communities. And there were quite a bit of work happening there. And the other team was Aboriginal and Torres Strait Islander communities. So I will maybe share a little bit of my cold experience, because I know you have a video. So there, that was another very rewarding experience in my career, just because, so as part of that role, I was like, we were going out to communities and talking with women from different countries, like mostly for first generation Australians. They would arrive here from different countries, different culture, different backgrounds. English is not their first language. So we would contact the community centers. So we would gather all these women and we would go and talk about sexual health, reproductive health. And some of them would be, like my mom's age. They would be like older than my mom's age. So it was such a rewarding experience just talking about, and also realizing that many of those women might not have heard about cervical cancer screening. So I was looking at the swab. I remembered those days that I would show that, okay, it was pap smear, maybe you have done it, but now in Australia, this is CST or cervical screening test, and how simple this is. And we talk about also, many women would have adolescents, kids. So, just how to talk with your children about about puberty, so which was really, really very, and sometimes it felt like I'm talking with my moms and aunties. So which is a really nice experience. So part of that was that. And also we would go to different schools and where young girls would have conversation, and they would be so shy, and then at the very end they would just come to you and ask a question. So those are very small, I think, happy moments, like when you can see that you have made that environment safe for them to really speak up and ask those questions they might not be asking someone. So I think those were really nice. And then as part of that, those days, I also worked with some young people from, again, I think she was from Iran. I cannot remember, maybe Iran. So I created this in resources, so quite a few resources. One I will speak about, it was on consent. And then, we want to consult with these young kids, like, what do you want in that video? What do you want to know? What is very difficult for you to talk about? So then we had a consultation, we engaged them and had this amazing video. We worked with an Indigenous artist from Australia to do the graphic design, which was amazing. Keisha, I just want to shout out. She's such an amazing person to work with. And then, so the voiceover was done by a young person, and that was the video Rachel will show today. But that video had been then adapted for Pacific nations that we're working in family planning under the international team. I think I remember when I was leaving family planning, I did the project plan. Oh, we have an existing resource. Why cannot we customize it for, you know, we can save some money, some cost, but it just needs to have proper consultation. So it fits the audience that we are like, you know, it's appropriate for the Pacific children and the sensitivity and the cultural consideration. So I think I remember this day. So good that you will share that. So that was family planning, domestic, and then joined the international team for a while. And there I was supporting with the comprehensive sexuality education program, rolling out both in school and out school for in school and out school young people. So it's like, you know, how you incorporate a topic like comprehensive sexuality education in pre-service teacher training and in-service teacher training. That's for in school and then out of school. So working with the Ministries of Health and Ministry of Education and having extensive consultation. I remember with youth workers and then Ministry of Health officers, and it was a 1,000-page manual. I was like, good luck with that. So that was really exhaustive work, but I think I didn't see the rollout of it before that I left. So, but I know that had been used for training, so which is amazing. So that's kind of a little bit of it. And then moved to Child Fund Australia, where I'm currently am. So there, so we have, we are doing quite a bit of work, and Child Funds, our focus is to, improve the outcomes of children in health, education, safety. So I'm overlooking the health work there, and we have some amazing country office colleagues. We have Child Fund offices in Asia and Pacific. So my health portfolio is around mostly in Papua New Guinea, Timor-Leste. Some works are happening in Vietnam. I'll not go too much in detail what we're doing, but I think talking about sexual and reproductive health choices, which is the topic, I think we're doing some amazing work, centering women and their rights, and just we're directly working with the communities, which is, I think, different at a different level, gratifying, and then just nice to work with them, work for them, and also not only working with women, but also engaging men in and how to create that environment for these women to access their rights to health, especially sexual reproductive health, and the countries that we work in. And coming from a country very similar cultural context, and where you have those stigma, you have those societal barriers, and then gender discrimination and gender-based violence is so high. All of this cross-cuts with sexual reproductive health in so many ways. So I think some powerful work we are doing at Child Fund. Very happy to talk more about it if anyone's interested. And I will just finish up with some little work that I had been, again, going back to Bangladesh. So supporting in a consultancy capacity organization in Bangladesh who have started a kind of national helpline for young people to talk about sexual reproductive health, mental health, and gender-based violence. I was like, wow, where was this when I was a young kid? So I think when I was doing the desk review, it's just amazing to see that since 2017, I think, comprehensive sexuality education was formalized in the national curriculum of Bangladesh. I was like, yeah, early 90s, we didn't have that. So, which was very, very, I think, I felt proud that, you see development, you see those progress. So I think, which was nice to see that these young kids have many options now. They can call someone being confidential and then ask questions about. So, and they did a study in the phase 1. So during COVID, I think more young boys were calling that line, but after COVID, the more women started like seeking those services. I think it's interesting to see those shifts in gender, and more young girls are feeling comfortable to seeking help. So in my country, so that was nice. I'll just end here to just share. Thank you. Thanks very much.
Thank you so much for sharing all that, and particularly the personal example. I feel like really ties it together. Of exactly as you said, it's so nice to see development over time, that there's tangibly a difference happening in Bangladesh now. So thank you for sharing that. And last but not least, we will head over to Rachel. Would you like to discuss the videos first and then we'll play them? Or
I can do an intro
Mhm.
first.
Go for
and
it.
then, so there's a bit of a context. So hi, I'm Rachel. I work at Family Planning Australia. Thank you to both of you who've talked. And what I found really interesting is how we work in sexual and reproductive health, but how we bring ourselves, our backgrounds, our personalities, and our experiences to that workplace. Because I guess in Western viewpoints, it's like, no, you go to work and you have your work personality and you perform those tasks and you meet your KPIs, but we don't look at the person who that we bring. And that's such good examples. And especially as women, you're bringing your whole self to there. So I fell into sexual and reproductive health. Everyone does a master's in public health, so I did mine. And I originally did communications, and then some of you might remember a little program called Youth Ambassadors for Australia, where bright, young, shiny things like myself, who just graduated uni with pretty much not much to offer, for me, I mean, there were others who did, we were placed in organisations overseas, and we were meant to build the capacity. Okay. It was a long time ago. Okay. Things have changed. And I got sent to Vietnam and loved it and worked in environmental health. Which I had no interest in, but I still liked it. And then I did become interested once I worked in it, and then did public health. Then I got a job at a community health centre as a health promotion officer. And so I was doing stuff around domestic violence, mental health, but we also had a needle and syringe program attached. Do people know what they are? It's a HIV strategy where you give out free equipment, injecting equipment and advice for people as a HIV prevention thing. Anyway, they were constantly short-staffed, and they're like, will anyone come and help hand out the needles? And I was like, yeah, all right, I'll do it. And then I knew nothing about it, but the clients were really nice. I'm giving them what they want. I would say, I don't know, you're going to have to tell me. And they taught me how to inject. But they taught me so much, and I ended up working there full time. So I moved from one team to another, and then I started working, and a lot of sex workers who were street based, who were injecting drugs, were coming in, and I liked them as well, and they taught me a lot as well. And then I started working in HIV and drug and alcohol and things like that. So I fell into it by mistake. But I think when you think about bringing your whole person to work, I'd grown up in a conservative environment, but it always never fit in because I was, in my opinion, my mum just says I was difficult and rebellious. I think I was actually just more open-minded and non-judgmental. But I also grew up in a very sexist working class environment where men did the lawns, women did the housework, men drank like fish, and you knew about domestic violence. We were raised in domestic violence, and you never challenged it because the man was the head of the household. Those attitudes still do. So I think subconsciously, because listening to you guys, I was bringing that to a lot of my work, and I was like, that's just not fair. That's not right. Why should we? And, Catholic school, our sexual health education, we did watch a video about giving birth. It's horrendous. And I mean, as a contraception, I think it worked really well. But the thing was, don't get pregnant. And, because boys, that's all they're going to try and do, and, all this kind of stuff. And, we watched anti-abortion videos at high school kind of thing. And, now when I think back, I'm like, maybe they planted that seed that this is more interesting. What's going on here? So, yeah, but in terms of what I do at family planning, so comprehensive sexuality education, I think the Pacific is in some ways more advanced than Australia. So if you look at the Safe Schools program that we had here, that's comprehensive sexuality education. Not so popular here anymore, but in the Pacific, they're embedding it in teachers' learning. We have a lot of the NGOs that we work with church leaders and other people who are promoting women's rights, promoting contraception. And when I sort of talked to some of the partners in country and talked to some of the even older people in the community, at first they're like, we were really anti-contraception. We thought it was a way of controlling our Pacific communities who tend to like bigger families. It was a Western way of like eugenics kind of thing. I don't know, how do you define eugenics? Like population control of what was done in Indigenous communities kind of thing. And then they were like, and then my teenage niece got pregnant and she couldn't go to uni anymore and she couldn't do this, but now she's working and I'm looking after the child. So now, and I just remember one guy was like, it's an older man, so now he's like, I'm walking around my neighborhood saying to people, you need to get contraception. You need to get your teenage daughters on contraception. And he's like, yeah, he's really, was like, it's such an important thing. Yeah, and it's when you hear those kind of stories, and I think for cervical cancer as well, and for other STIs, most of the people that I work with in the Pacific know someone who's died of cervical cancer, and they've died young, like in their 50s, and they've left families, larger families. So they really feel the impacts. So sexuality education, and we're talking gender diverse concepts as well. A lot of communities are embracing this. Some schools are like, no, we're not going to do this, or teachers are really uncomfortable, and we work with them around that. What would you do? And it's staged for, like, you don't go into kindy at that, like it's staged across levels. But I think things that we won't do here because it's a bit conservative at the moment, people in the Pacific are doing. So we've done radio programs. I'm going to show some social media animation that we've done, and it's all sex positive. We try and include people with disabilities as well. A big gap is people with disabilities don't have sex lives or aren't sexual, or disability is misunderstood. So we try and sort of break those myths. We do programs with disability schools. I don't know what they're called, sorry, but where parents and children are educated together, and we talk about puberty and contraception and all that kind of stuff. So because, having a disability makes you more vulnerable to future violence. There is a lot of coercive issues and gender-based violence issues, as I think there is in Australia. I don't want to say I think it's more or less. I think every community has it, and we're all trying to deal with it in different ways. So a lot of what I see in the sexual health space and what we hear from patients is men controlling women's sexual health. So we've got implants in people's arms, Implanon, Jadel. So I'm looking at the clinicians. Yeah, I've got it. Yeah, I'm like the rod, yeah. And men will be checking their partner's R's because they think if you're on contraception, you're being unfaithful. That's why. So we've had women who won't go for cervical cancer treatment because you can't have sex for a month or 6 weeks after. And they're like, you're just lying. It's because you've been with someone else. And yeah, so there's still a lot of men's control. In Papua New Guinea, there's now a contraception that a village health worker can have that can be injected that will last for 12 months. And the partner will not be able to feel an arm or something else to find out. So there's new contraceptive, and you can just go to the village. I'm saying because we know it's village health workers, but I could keep it for Nusrat. And you could pop over and see your friend, and I could have that supply if I'd got it. So there are ways around this, but attitude change takes a long time. Like, I guess my point is, when I was growing up, we never said domestic violence because it was kind of just normal. But now, like, my mum is like, I can't believe how openly everyone talks about it. And the services, she was like, you just put up with it then. There was no, if you're lucky, you could go to a refuge. But if you called the police out, they'd be, what did you do to upset him? And I mean, still, that might still happen, but it's so much less. And we screen in hospitals for DV. We have all these services. So I think behaviour change takes a long time. And I've got a couple of videos to show. Are we ready for video time, or yeah? So the first one, okay. I think the first one is on contraception. I've given you the English version because I didn't think anyone spoke Fijian. So we have it in language. So are we doing? Yes. And this went out on social media and I think the government wants to put it in cinemas. They really liked it. Yeah.
What kind of future are you planning?
How is your study going? Pretty good, but I'm stressed about economics. Me too, at least you don't have to worry about getting pregnant anymore. That's true. With my loop, I've got years to finish my uni.
Use contraception to plan your family. Condoms prevent STIs and pregnancy.
Okay, that's just on the loop, but we did it on all sorts of different contraception and showing girls in school uniforms was a deliberate choice because we want you to control your health and your education. So there's we did a whole series on this. Oh, we can go through, do you want to, there are 30 seconds each. Yeah, sorry, you're going to have to watch it. I've started it now, so we're going, let's go for it. Maybe go on the pill. I like the pill one.
What kind of future are you planning? I can't believe Sarah and Michael are having another baby.
Already? What about you? Are you using contraception?
Yes, I take the pill every day.
Great choice. You can have kids when you are ready. They're so expensive to feed.
Hey!
Use contraception to plan your family. Condoms prevent STIs and pregnancy.
That's the same all the way through. So I won't make you watch the others because then we've got condoms. And this is the consent video. So I'm going to do a shout out to Nusrat.
I'm not sure what you have changed because of
Nusrat's never seen this, so it's a bit of a show and tell. Okay, before we hit play, so 3.5 years ago, Nusrat said, I'm leaving family planning, and I just started maybe a month earlier, and you said to me, I think you should apply for my job. And I said, no, I haven't been here long enough. I have not that experience. I don't know. And you said, don't be ridiculous. Apply. And I applied, and now I do it. So one of the things Nusrat handed over to me was a video on consent in relationships, and we use it in a lot of our training materials, and we adapted it for Fiji and Vanuatu, and Fiji government also wants to show it. We just haven't worked out the IT on how to cut out because we're promoting an NGO and we need to, anyway, I'll bore everyone with the details later.
when I did it, it was for Australia, but not to the Pacific context. So I want to see what change have been made to that.
Yeah.
to make it more.
Well, this is the Vanuatu one. So all the voiceovers are done by peer educators, so people who work at the service that we're promoting. And they went to the local radio station and recorded, and they also did the script, a little bit of script change. So they're all local voices.
The colours remain same.
Yeah, all the, no, some of the, there's some changes, Nusrat.
Okay.
Yeah, yeah. Okay. Done.
Wanam now hemi consent. How na you give him consent, ma how na you save sipos nara fala wan is stop give him consent, alright.
Consent in meaning say you want more stop give him permission or tell him also about some action say your right plong make him want something or same sex.
Emi save kind fasin or send you stop kiss, stop hold him or stop touch him body or some kind action where is save pity mole emia or some cat sex with them nara fala.
Might I heart lel pet plong talk about be emi important to must say you save long consent suppose you stop finish long one relationship or you stop ting plong cut one relationship or stop cut ting plong married long future.
Mo yes, it true say you need him consent even suppose you married finish or you stop long relationship finish. More too, you need him consent suppose you no stop long relationship where you want them block at sex with them nara fala.
So how now you save say you cast him consent long one nara fala? You ask him.
Might you ask him all same? You alright with the one you me stop make him? You want them you me go ahead or no? Sometime him you want simple yes or no.
Sometimes it's a very hard lelpet plong kasem suppose you got consent plong narafala. From say might oli no tok be oli swem plong you through long potilan wis plong olgeta. Oli foltem crossem han plong olgeta o oli sevet I go long way long you. Olgeta accent olsem I minim se oli no like him, oli fright or emino alright. Suppose oli no alright you must stop him one way you stop make him.
You need him consent every time you got sex. Hemi important to mas. From se sipos partner plio italem yes one time finis, ino minim se you kasem consent blem all time.
More too, want something where emi important to us, say you or partner plong you is a Chinese him ting plong you to fala anytime. Suppose you or partner plong you in no more like him one way it stop happen, emi straight no more plong stop anytime. Remember say consent emi save stop plong anytime. To fala partner only need plong communicate good time only stop give him or only stop ask him consent. Suppose wanara fala is sleep, I pass out from itrong to mas or ipon, emi no save give him consent. No matter say emi been give him consent finish before he pass out.
Lo fan watu one boy or one girl I must cat age plus 16 year or beat him 16 year plo give him consent plo cat sex lo heterosexual relationship man mo woman. Lo one homosexual relationship man mo man or woman mo woman. One boy or girl I must cat age plus 18 year or beat him 18 year. 16 year emi illegal age where one girl or boy I pick one enough to give him consent to have him sex. Emi I mean him say time you got 16 year I contact you pick one enough to tell him yes mo agree to got sex. Suppose you want to save more lo consent, you save inbox Savannah to Family Health, lo Facebook or call them 22140 or Campusum Head lo clinic we stop behind lo Olvala police station.
Is it that different?
No, I think it's the concept is the same because I was more just thinking about, like, like sex, kissing. Where all those slides consulted tested with the youth and then they're okay with this to have on the slide?
Yeah.
Okay, that's good. Yeah. Sorry, I want to know.
Actually, so you see how we had a same-sex couple? So Vanuatu is going through a very conservative period. So the local LGBT plus organisation the government is trying to defund it and deregister it. There's a lot of backlash at them. I mean, things go through waves, and I wasn't a good development practitioner, and I said to our partners, we're going to include what do you think about a same-sex couple? And they were like, you need more. There need to be more same-sex couples. And I, as not a good developer, I was like, it's too much, it's going to get shut down. So it's that balance sometimes of politics. Is it going to be bad if you only have one same-sex couple versus two? Sometimes you've got to pick your arguments, and they're like, okay. But in terms of being a bad development practitioner, we're taught you've always got to listen to your partner, you always do what your partner wants, you always deliver to your partner. I just wasn't sure. And when we did launch this, communities loved it, the people loved it. Some of the more senior DFAT people were concerned. Yeah.
As long as the community, consulted the community and then they were okay with it. I think that's most. And what I liked about it, when you are under influence of drug and alcohol, I saw a guy was sleeping and the young girl was standing. So I think it was nice to see the other way around. Usually you are so used to see, okay, a young girl might be under the influence of drugs and then she can be the victim of violence or anything. So which is nice to see the shift. Yeah. Thank you. Thanks.
I wasn't a totally bad development worker. But anyway, that's me. I just thought it would be good to give you a practical example. Yeah. Anyone who wants these, we're happy to send it to you as well. Just take out the bits you don't need. I don't know how to do that technically. Sorry.
Okay, well, thank you so much for that. And again, really pushing show and tell and the stories and the things we can use. This was fantastic. Okay, I have a few questions I can go into if anyone's feeling shy, but you have all been very patient. Does anyone have some questions for our lovely speakers? Oh, yes, Tamara, would you like a microphone? I can run that out to you. We just press the button. Just there.
Thank you. All of your discussions were so interesting and great to hear from this issue from different perspectives. Yeah, so we sort of started to talk a bit about backlash, but yeah, I'd be really interested to know if you've seen a shift in any of the countries you work in or with in the Pacific and Asia around sexual reproductive health rights. I'm assuming there's a bit of mix in terms of some areas are progressing, some areas are going backwards, or like in having barriers to implementing programs. So yeah, I guess come at that question however you'd like. Thanks.
Any takers?
So I thank you for your question. I think probably we will complement each other because the experience I have here in the Pacific probably won't tell me this progression across the last couple of years. What I've seen it is, at least for cervical cancer, and how open are the countries and how they see it as a priority, it's quite remarkable. And I can't imagine that happening many years ago, or even 5 or 10 years ago. So they do recognize as a priority, they see it, the impact in future generations that we were speaking, that a lot of these women, they die young, in young ages. At least in Timor, whoever I speak, they know someone or an aunt or a friend or a neighbor who has died to cervical cancer. So this is quite a topic that people are talking about, and not just only the sexual and reproductive health. I will add here, talking about cancer, it's quite difficult as well, even in our society. Imagine in these countries with many other barriers. So I think we are building that momentum, and probably thinking about integration of some of these initiatives might be a good way to even strengthen more how we approach them and how we show these links with different areas. There are some work in this integration of cervical screening with family planning activities that are already happening. So I think there's a lot of interest, at least from the countries, and they are pushing for us to support them to move forward, which is a great sign, I would say.
Oh, no, that's you can, I can share from the, sorry, just get this, the programs that we are doing in Child Fund. So I just give a very recent example. So I visited Papua New Guinea for work, and then we have this group of, I think you mentioned community health volunteers. So in Papua New Guinea, we have a group of, we call it village health assistants. So they're community members who we kind of give a very basic training on fundamentals of health promotion and knowledge education. So what we started doing is very slowly started the discussion of gender-based violence with the community men. So we have this, our project officers and village health assistants who are male. So we kind of equip them with very essential knowledge of this to start a discussion and gather these men together. So, and we support government with this, we call it outreach health services, which is kind of a one-stop health service where all the community village people will gather because they're living so far away. So formal health workers will bring essential like family planning or antenatal care for mothers, or very basic health checks for young children. And then we take this opportunity, I'm going a long way to answer your question, but I'll come to your point. So we take this opportunity to gather those men and start talking about gender-based violence. So when I was visiting, I was just sitting on the one corner, and then one of the project officers said, oh, you know what happened today? This group of men, they was asking, oh, when are you going to talk about family planning? So it was interesting because we know there are quite a lot of resistance from the men in engaging maternal health or reproductive health. And often we see only women or mothers are taking their children or just going to see for antenatal checkups in health clinics. So it was very interesting to see that men are wanting to know about this and understand a bit more. But also at the same time, we also know that, you know, who is making the decision of what reproductive health choices as a couple you're making. So most of the time it would be the men, right? So I think there are definitely some difficulties, but we see more interest. And we also have been noticing since, you know, like I can just talk about child fund at this point, like, you know, I know that we are trying very hard to engage these fathers and for them to come and attend clinics with their wife and children. So we are seeing higher percentage of men are slowly engaging, where still there are challenges, but definitely we're seeing some progress from the community, and there are definitely interest from the at a system level from the government. And otherwise we would not be able to, I think, do this, but we are just trying to do it in an approach that is most suited for the community we work in. Yeah, so that's just very long answer.
So yeah, I think there is backlash, and I think there's backlash on the gender, trying to change gender norms. I think there's backlash around a whole lot of things, but remember, a lot of that backlash is being created by USAID and other international players. So funding that may have gone, I mean, I think that's coming from a community level as well, but I think funding has been cut to grassroots agencies who are promoting sexual and reproductive health. But I have to remind myself that change is not linear. I think the cervical cancer, from my personal opinion, there's no research on this, is that program and the changes in addressing cervical cancer is because of a sustained advocacy over 10 years from a lot of agencies pushing and pushing and pushing. And now we're seeing the results. So change is slow, but I think there is backlash, but some places I think are more, like when I was saying in terms of school programs, are more advanced than we are. And I mean, Tuvalu started doing, does anyone, Tuvalu, tiny little country, good development people know it. They started doing self-collected swabs before Australia. So it's very contextual. Does that answer your question? Okay, cool. You can say no and I'll be fine with it. I mean, we work in sexual health. We've heard stuff. Yeah, we're strong.
Fabulous. Okay, thank you for those answers. And absolutely, whether, you know, people feel like they want to continue discussing the answers that are given or have other questions you just don't want to ask in front of the group, we have plenty of time to chat. Are there any more questions from our lovely audience? Because I have one that was submitted online from someone registering, and I might direct it to sort of touch on all of you of key things you would take away here. What are the skills and experience you think that early career professionals, my goodness, should develop if they want to work in this area? What can they start to do now to build up working in sexual and reproductive health?
I think you have to, study public health. Yeah. It is a good entry and it's a good general entry. But the other thing is you need to be comfortable with the ick factor. Okay, so sexual and reproductive health is, you're going to hear stories, you're going to have to be comfortable with disclosures. You know, there may be people who've experienced trauma. I think as a person, you need to be open-minded and non-judgmental. And we think that we are, but sometimes, you know, if you're not truly into it, no. Can I ask, how many people actually want to work in sexual and reproductive health? Be honest, you do? Yeah? It's hard to get into, I feel, at the first because it's very niche. So I would say get experience in other health promotion, and like Nusrat did with working with young people. Working with young people is a great entry. Also working with First Nations people, there's a lot of similarities in terms of colonization and impacts. So I don't think people come straight to sexual health.
Thanks, Rachel. I will not say do public health, but but
you did public health as well, didn't you?
No, I didn't.
See, we don't have to do public health for this.
But we do have to, yeah, even if it's not formally, in terms of the way of thinking and in terms of the impact that it's not a one-on-one, that I need to make that shift. So I was very used to do this impact on one-on-one basis. So the relationship with the patient, and it's precious, and I carry it with me, and that's part of who I am. But actually we have to shift the way we think, and because it's at the higher level and the impact might not be seen at short term, and sometimes that might be a little bit frustrating as well. So yeah, but I didn't do public health.
And for me, I think I just see it like how important your other health is, right? It's your right to have this sexual reproductive health and access to it and practice this right. So I think, and I keep challenging outside of my work if someone would, if I see someone is stigmatizing, but it just who I am, I would just say, oh, this is important part of your health. It's nothing to be ashamed of. And you can, I think those passion and advocacy also helps in your profession, I would say, because you as a person, you're coming to this space and you're advocating for something you believe in. So I think that's more important to me. And education is just a certificate. So that's what I think it's important. Yeah.
I was going to say getting experience in the domestic violence sector as well. I think that's a very transferable skill across to sexual and reproductive health. So yeah, get those transferable skills, and then but there's not a huge major thing of opportunity. Sometimes you might need to work domestically. I don't know if people live in the inner city, but sometimes you got to travel like western suburbs. I live in the western suburbs now, but when I did first start, I was in the inner city, and people were like, oh my God, you're going out to Blacktown to work? Like, it's like, well, it's the only place I can get a job that will employ me, but in the field that I want. So you're going to have to step out of your comfort zone and your dream of what you want to get that experience. I now live in Blacktown. Yeah.
If anyone else has questions, I think we might need to just wrap up now. So if you'd like to ask them in our networking session, or I'm sure our lovely speakers would be happy to connect with you after tonight, we might do it there. But I might ask just one more to wrap up is, given that a lot of our attendees tonight aren't working directly in sexual and reproductive health, but work elsewhere in the sector or are somehow connected, what can we take away and incorporate into other areas? What sort of knowledge do you think is important for us to have in those other areas of the sector?
They might not think they're working in sexual and reproductive health, but there'll be a crossover. So if you're working in environmental, you're looking at menstrual hygiene, wash facilities, things like that. That includes sexual and reproductive health. If you're working in education programs or community programs, there will be a sexual and reproductive health component. So it may not be the main focus, but there will definitely be an element. All of our programs, I think, in development look at women's equality. That is the basis of sexual and reproductive health. So you might not think you are, but you are in some way.
And also I think a lot of work we do at Child Fund is social emotional learning that has a very strong interconnection with sexual reproductive health. So if you end up doing something in SEL or social emotional learning, that is something, gender-based violence, like strong connection with reproductive health, right? So I think those things, education sector you already mentioned, in schools, and like as long as you're dealing with a human body, they will have their rights to sexual and reproductive health. So I think keep that in mind, like you cannot ignore that. It's just, it will come. So, and we need to uphold those rights. Yeah.
Not going to focus on sexual and reproductive health, but on the whatever the field that you're working, just try to think about the big picture and how we complement each other. In terms, and I've mentioned that that's one of the things that get very passionate about in the program I'm working in is how we bring different partners and work with different layers within the same country to make the puzzle fit. And again, working at the policy level to be active on that level and to define what's going to come next and make things more sustainable, but then going down at the community level and making sure that we are actually actionizing those beautiful policy documents and making them translating into reality. So in whatever the level that you're more interested in or working at this moment, think about that it's not just that, you have to connect with the other levels and be open to that as well. So yeah, that's it.
Thank you so much. And I know I'm definitely going to take some of this from tonight back into my work and bear that in mind. And I think those were excellent points of whatever level you're at, any person you're working with, your work does intersect in some way with this. So on that note, thank you so much to all of you for your time and your experience and everything you've done for us tonight. So can we please have a round of applause? We've been very happy to have you. We would have loved to give you each a small gift to show our appreciation of a Women in Aid and Development mug. We will send these to you because we don't have them tonight. But so imagine the iconic mug that we give to every speaker. But I'd also like to thank the rest of the Women in Aid and Development Leadership Group who've supported us with the smooth running of tonight's event, and to Canva for hosting us in their beautiful space as always. And an extra thank you to Chris as our chair who brings us all together. So that brings us to the end of our discussion portion. So please stay in touch and connect with us online, either through the website, the Facebook, or the LinkedIn. I highly recommend that you join the mailing list if you're not already on it, so we can keep you updated on events and opportunities. And if you'd like, you can become a Women in Aid and Development member, which will assist us financially, as well as giving you the opportunity to participate in our mentoring program, either as a mentor or a mentee, depending on where you are in your career. And you can find out more about that on the website or come and chat to one of us. Our next event will be held online in July on the topic of young professionals entering the aid and development sector. So this will be a really fantastic discussion for people at the beginning of their careers. I'm seeing a few of you. Or those looking to make a career change, and also for those who've been in the sector for a long time and have more experience and have something that they could really contribute to the discussions. So we'd love for you to chime in. Finding out those details for that event is another reason for you to join the mailing list. But for now, that is the end of tonight's event. Please feel free to take any leftover food as we start packing up, and remember to get people's contact details, or you can always plan to catch up at the next event. Thank you all for coming, and yeah, we'd love to see you next time. Thank you to those of you who joined us online. We hope you've had a great night.